Hello, friends. So I'll be talking about this interesting topic. So vaccinations in and adult intensive care. So what is the correlation and what is the impact of having patients who are not vaccinated in adult intensive care? So this is a little offbeat topic. And this has become a lot more pertinent in the light of COVID that has come. So if you recall, the second wave of COVID in India was pretty bad. But the third wave, which was caused by Omicron, so we witnessed there was much lesser ICU admissions and much lesser morbidity and mortality. And we could possibly attribute this to significantly the less virulence of the Omicron, but most importantly, the vaccination. So in the backdrop of this, it is very important that we see how the vaccinations in adult patients in other diseases have an impact on intensive care. So this is sort of a review of literature, and which is quite interesting. So there is a good article that has come, so you could read that. And it just gives emphasis on the importance of vaccination in the adult intensive care patients as well. So when you look at the literature, so there is a strong correlation between the vaccination status of a patient and the ICU admissions, especially in the vaccine preventable diseases. So there are a few diseases that I'll be touching, which is something that we would see in intensive care, in adult intensive care. So the vaccine preventable disease has a good correlation with the vaccination history of the patient. And it is shown that 9.3% of ICU admissions that happen are due to vaccine preventable diseases, which would have otherwise been prevented by effective vaccination. And I'm sure all the listeners here would know one of the commonest virus that we deal with is the flu virus or the influenza virus, which constitutes about 3.4% of the ICU admissions every season. So we witness this, and this reemphasizes the importance of effective vaccination. And it is shown that with good vaccination, especially in the vaccine preventable diseases, one could reduce the ICU admissions and one could possibly reduce the complication, morbidity, and mortality of the patients if they had been vaccinated, more so when they come with vaccine preventable disease. And the pathway of the vaccine has been blocking, and this is more so in lower middle income countries. And when we say the pathway is rocky, it means there have been certain disasters that the vaccine-induced polio, which happened, is possibly one of the disasters that happened with the vaccines. And the fake news, especially with regards to vaccine hesitancy, leads to patients not really being forthcoming to take vaccines. And scientific misconduct that has happened where there was a measles outbreak. So these are some of the examples where it creates a bit of a distrust and loss of confidence in public in going ahead to getting effectively vaccinated. And we have seen this vaccine hesitancy, which was a problem even with COVID. So these are some of the issues that revolve around the vaccine. And the WHO puts vaccine hesitancy as one of the 10 global threats that mankind would be facing. And this is something which WHO puts emphasis on addressing this vaccine hesitancy and try to promote effective vaccination to reduce the burden of vaccine preventable diseases. So this is something which every listener should bear in mind. So we'll talk about certain diseases that are effectively prevented with good vaccination and reduces the burden in ICU admission. So Haemophilus influenza, which is seen more in children. So this has shown how vaccines can lead to disappearance of intensive care, especially in Haemophilus influenza. So that's the way H influenza looks. So the Haemophilus influenza can cause meningitis, and 30 to 40% of the patients can be left with neurological sequelae. And epiglottitis, which is caused by H influenza, can be devastating, which can lead to 40 to 90% of case fatality rate. So which has a very high fatality, especially when they have an airway issue secondary to epiglottitis. And H influenza can cause pneumonia and can cause sepsis when there is a disseminated infection. So this sequelae, this epiglottitis or neurological sequelae and all this can be significantly mitigated by effective vaccination. And H influenza B conjugate vaccine, which is called HIB vaccine, was introduced in 1990, and this has seen good success in preventing H influenza infections, also in children, and significantly reducing the H influenza infection. But the uptake of this vaccine has been slow in lower and middle income countries. And Global Alliance of Vaccine and Immunization emphasizes the need for H influenza B vaccine to be incorporated in the regular vaccination schedule. And I'm sure many of the listeners would know that they would have this vaccine being a part of their vaccination schedule for their kids and so on and so forth. So this is something which has again shown tremendous success, having included in the vaccination schedule how it can reduce the burden on the ICU admission. So, and this is the sort of a graphical representation how the prevalence rate of severe infections has significantly come down from 99 to 46% from early 20th century to more recently. So now let's look at the Streptococcus pneumonia. So I'm sure many of the listeners would know that elderly patients in ICU, we do suggest vaccination against this pneumonia. So here now there is an emphasis on conjugate vaccine as found to be superior to the other existing ones. So when you look at strep pneumonia as the commonest cause of community-acquired pneumonia, and the most community-acquired pneumonia we see in ICU predominantly is caused by strep pneumonia. And we know that strep pneumonia tends to affect children. So it tends to affect extremes of it, either children or elderly patients or patients with lot of comorbid conditions. So they become vulnerable to strep pneumonia. And the case fatality rate due to strep pneumonia is put at 11 to 30%. And it is shown that the risk of strep pneumonia increases with increase in the number of risk factors that patient would have. And the important risk factor for strep pneumonia is especially recurrent community-acquired pneumonia due to strep pneumonia, especially in elderly, is attributed to failure to get vaccinated every year with the pneumovac vaccine or the conjugated vaccine. So this is something which is in our hands, in intensive hand, where we should possibly promote every elderly patients to get this strep pneumonia vaccine so that the disease burden can be lessened and their morbidity and mortality can be lessened, and need for ICU admissions also can be lessened. So there are two types of strep pneumonia vaccine. So one is the 23-valent polysaccharide vaccine, and this is more so has been recommended for elderly patients 65 years of age. So this is produced by Merck. And so this is a capsule purified polysaccharide, which sort of elicits the B cell response. But the problem with this 23-valent polysaccharide vaccine, which is pneumovac, you would have heard, produced by the Merck, it elicits B cell response, but there is no immune memory. So the whole problem with this vaccine is the immunity that is conferred is short term because there are no memory cells that are elicited by this vaccine. But the conjugate vaccine, which is produced by Glaxo, so this is preferred for patients who are less than 5 years. But the advantage of conjugated vaccine is it elicits B cells, it elicits follicular T cells, and it also elicits good T cell response, and it produces very high antibody levels. So now the whole thought process is even the elderly should possibly be considered for this conjugated vaccine because of the good memory cell response that it produces and a longer immunity that it confers and higher antibody levels it provides. So this is something which is being sort of deliberated upon, that conjugated vaccine may be much superior than the 23-valent polysaccharide vaccine. So that is something which is food for thought for all our intensive colleagues. So when you look at this beautiful graph, which shows the pre-vaccine era, so where the vaccine preventable disease, if you see, they were very high. And as the vaccine coverage increased, you see it was directly proportional to the reduction in the disease burden. And where there was a outbreak of polio or measles outbreak due to vaccine, so where vaccine hesitancy prevails, you see a small outbreak of this disease, which tends to happen, and the vaccine coverage also. So which means to say wherever there is a reduction in the vaccine coverage, outbreaks tend to happen. But when there is a resumption of confidence, you see it directly is proportional. So the effective vaccine coverage has been directly proportional to the lessening of the burden of the vaccine preventable disease. So this is something which is very important, which we have witnessed even in COVID, where when we witnessed the third wave with Omicron, we saw the disease burden was much lesser and the need for ICU admission was much lesser. And now that is something which we need to keep in mind. So another important disease that one could possibly see in ICU, which is vaccine preventable, is tetanus. So the importance of boosting immunity and physician's memory. So tetanus is known to cause 50,000 deaths per year, and these deaths tend to happen more commonly in lower middle income countries, and these deaths predominantly are due to lack of ICU bed availability and patients not having taken booster dose. And there needs to be emphasis on recognition and treatment of this disease, because this tetanus disease is not commonly seen. So recognizing this disease and initiating appropriate treatment will possibly be delayed because of the rarity of this disease. So the authors emphasize that the boosting the memory of the intensivist and emphasizing the importance of the need for booster dose if someone has not received for tetanus becomes very prudent in mitigating this disease prevalence in ICU, or lessening the burden of patients during ICU admissions, morbidity and mortality. So that's the thing about tetanus. So one should keep in mind about the clinical presentation of tetanus and the importance of a booster dose in patients who may not have received for tetanus. And if you see this, so this is the article that came in the headlines in Times of India today, which is 24th of April 2022, where it is said that 15 districts haven't given a booster in significant proportion of patients. So this is again a cause of concern. If you recall that graph that I showed you, so wherever there is a reduction in the vaccine coverage, there is a potential for a surge in the cases, and we have been hearing about surge of cases in Delhi. So it is very prudent after the 2 doses of COVID vaccination. It is imperative that the booster dose is effective coverage is done so that this surge in the cases could be avoided. So this is a typical example which historically it has been shown. And why the subsequent booster dose, or so you would see that the immunity tends to wane and the secondary immune response is needed with an additional dose, and for increasing the memory cell pool that tends to happen with the booster dose. So now we will talk a bit on vaccine hesitancy, which is a bane of modern day, a threat for all vaccine preventable disease. We have seen this in COVID, especially the high income countries. Many of them have had this vaccine hesitancy issue. And it is shown that more than 99% reduction happens with effective vaccination with regards to occurrence of vaccine preventable disease. But the vaccine hesitancy is something that tends to prevail in the society, and the reasons are multifold. One of the reasons is vaccine preventable diseases like tetanus or cholera, or be it measles. So they are very rare. So public are fairly agnostic that these diseases is something that would affect them, and possibly they tend to have a sort of a wall in their thoughts that this disease possibly will not affect them. So that is possibly one of the reasons why they wouldn't care less to why they should be taking the vaccine. So because the occurrence of the disease is rare, so there is a perception in the public that they wouldn't want to have an hassle of taking a vaccine. Or some of them would have fear of injections, which is cause for vaccine hesitancy. And the third important thing, which possibly one would see, is public's mistrust in the government and in the pharma. So many public or the general public would think that it is a pharma-driven sort of a situation that pushes for vaccination or mass vaccination. We have seen this very often cropping up. And most importantly, the internet, all the material that is available in internet, which can be disturbing. So if you just put vaccine hesitancy with COVID, you would see an umpteen number of protests that has happened worldwide, with various sort of cartoons being depicted about the dangers of vaccination. So these are some of the strong reasons. The fake material that may be available on the internet is also one of the common reasons for vaccine hesitancy. So now we look at influenza, which is also a common thing. How vaccine hesitancy. So this is an important topic for sort of issue for intensivists, how vaccine hesitancy among healthcare workers propagates nosocomial infection. So we know the influenza or the flu vac that every healthcare worker, most intensivists are meant to take. vaccine efficacy is fairly variable from 8 to 91%. In fact, the WHO recommends that every healthcare worker should receive influenza vaccine or the flu vaccine. And one thing that every listener should know is the WHO recommendation for every healthcare worker to get influenza vaccine is to protect the patients that come, because they are at a much higher risk for transmitting the infection into the public. But the systematic review has shown that the strongest motivation, if at all healthcare workers takes this flu vac or the influenza vaccine, is with an intent to protect themselves or families. But it's the other way around. Healthcare workers are mandated to take influenza vaccine because they are at a much higher risk of spreading the infection to the public. And that is the reason why influenza vaccine has to be taken by the healthcare, because they are at a much higher risk of contracting the infection and spreading the infection in the public. So they have an increased risk of spreading. And it is even shown that a number of healthcare workers that needs to get vaccinated to benefit to one patient is vary between 3 to 50. And more so in healthcare workers working in long-term care centers, if they are effectively vaccinated with influenza, 60% of the infections could be prevented. And long-term care patients are someone who are elderly with a lot of comorbidities who may be vulnerable, and healthcare workers may be dreadful if they're not vaccinated that they can spread these infections to these patients. And the uptake of influenza vaccine is low in lower and middle income countries, but it is shown to be very good in developed countries like US, Canada, Australia, and Japan. Because I remember when I was in Australia, all the healthcare workers were mandated to take this flu jab every year. But here also we do take in India, but the awareness and the percentage of healthcare workers receiving it is much, much lesser than these developed countries. So now coming to the last bit, protecting the most vulnerable, how an intensivist or intensive care physicians can help. So generally it is shown that the compliance of the doctors to have a good understanding of the vaccination for the adult patients in ICU is very poor because of lack of awareness. I'm sure many of you wouldn't have put a lot of thought into the importance, including me, about the importance of vaccinating our adult patients or having a tab of their vaccination history. And many of us have a fear of vaccine-induced adverse events. And there is a whole misconception that vaccination should be avoided in immunosuppressed individuals. In fact, the studies have shown that it really does not make a difference, because even though the immunosuppressed patients may have suboptimal immune response, it is better than having no response. So vaccines are advocated in all immunosuppressed patients. So this is something which was a constant sort of a query that was being raised during even COVID. So one should encourage effective vaccination of all these vaccine preventable diseases, more so for vulnerable patients. So there is a good sort of a literature out there from IDSA, which shows the sort of a vaccine sort of a schedule for various immunocompromised patients, HIV, someone receiving chemotherapy, after chemotherapy, before stem cell transplant, after stem cell, after solid organs. So these are all the various vaccines that a physician should have some clarity on Haemophilus influenza, hepatitis A, hepatitis B, diphtheria. So various vaccine schedules are elucidated in IDSA website. So one could go through and have some clarity, especially for the physicians who are dealing with immunocompromised, where the morbidity and mortality of this VPDs or vaccine preventable disease is much higher. So I'll just take you through or run you through very quickly about the vaccine preventable diseases that we may encounter in intensive care. So rabies vaccine is one of them. We could encounter rabies in adult ICU. The mortality is 100%, but if they're effectively vaccinated, 100% efficacy is there. Cholera is something we would see in India occasionally. So as you see, the mortality in the with good ICU management is much lessened from 50 to 60% to 3.3%. And the vaccine efficacy is around 53 to 86%. And that's the reference for you. And the typhoid, the mortality now in this day and age is less than 1%. Before it used to be 10 to 20%. And the vaccine efficacy, as you see, ranges somewhere from 50 to 96%. And influenza, which is the commonest one. So during pandemics or elderly, the mortality can be up to 60%. Vaccine efficacy is a lot more effective with conjugated vaccine than the other one, that the polyvalent one that is available, 8 to 91%. And tick-borne encephalitis, the mortality is up to 35%, but vaccine efficacy is shown to be at 99. So obviously the vaccine coverage for this may be quite variable. Meningococcus, which is commonly seen in ICU admissions. So the mortality in the current situation is 40%. Historically, it was 70 to 85%, and the vaccine efficacy ranges from 60 to 82%. And pneumococcus, as I said, conjugate is better. So the mortality is 11 to 30%, and the vaccine efficacy is 77 to 100%. H influenza type B, conjugate vaccine, the efficacy is up to 100%. As you see, polysaccharide is little lesser, and the mortality is 40 to 90% historically. So shingles, so the mortality is much less, but it can be debilitating. So the vaccine efficacy is around 50 to 97%. Dengue vaccine is not really become very prevalent in India. So this is something one should possibly keep a tab on. So although the mortality is put at a very less, we do see sick dengues coming to ICU who tend to die. So maybe this is something, the uptake of this should be really considered in Indians sort of a situation where we have a burden of dengue, especially in monsoons, and vaccine efficacy is put variably at 30 to 60%. Even if it is 30 to 60%, it's still good enough to keep a tab on this particular vaccine. So all in all, as you see, these are all some of the diseases which are vaccine preventable diseases that tends to burden our ICU. And this is something which clinician can keep in mind. There are good effective vaccines that are available to reduce the morbidity and mortality. So in discussion, so as you see, the WHO suggests that 2 to 3 million deaths could be prevented with effective vaccinations. And this can be improved with a good vaccination. Additional 1.5 million deaths could be avoided. So the future pipeline, what the work is going on is to come out with a vaccine for HIV, vaccine for tuberculosis, and vaccine for malaria. And this would have a huge impact on burden of these chronic diseases and their admission into ICU. And respiratory syncytial virus and strep B vaccines have shown to have immense benefit in children. And so the future lies with developing vaccine against Staphylococcus, Staph aureus, which may have a huge impact on ICU admissions and their outcome. And there is work happening on vaccines in Pseudomonas infections. And if these vaccines come into sort of a practice, so this would be a real game changer, and this can prevent nosocomial infection and can be a very effective tool in curtailing antimicrobial resistance patterns. So this would be a real game changer for intensive care if these vaccines become available to reduce Staphylococcus aureus or vaccines against Streptococcus aureus and Pseudomonas. So this can really be a game changer in reducing nosocomial, which is a huge problem in ICU, and antimicrobial resistance. And there is a talk on boosting varicella immunity, especially elderly patients who undergo complex surgeries. They tend to get debilitated by developing varicella zoster. So boosting this varicella immunity before any major surgery for a vulnerable patients is something that is sort of suggested or might to be put on. And there is emphasis on maternal immunization, which can prevent tetanus, influenza, and pertussis. So this is the overview that we could get about adult vaccinations and the link between or the correlation between the vaccine preventable disease in adults and the ICU admission. So it's a very good article that came in recently. So one could go through this, and this is the crux of the whole thing. So it's good for every intensivist to bear in mind there are good number of vaccine preventable diseases that comes to ICU, especially in adults. There are around 10 diseases, fairly easy to remember, and there are effective vaccines available. So we should possibly follow very closely on the dengue vaccine, because we do see dengue deaths in ICU, and that is something which possibly should have an increased uptake in our subcontinent. So thank you one and all. So I would end with this beautiful quote: each of us is sometimes a cretin, fool, a moron, or a lunatic. A normal person is just a reasonable mix of these components. So thank you one and all.